Good morning, everyone, and welcome to today's webinar, COVID-19 Vaccine and Fertility Treatment Guidelines and Advice for Providers. Before we get started, I would like to go over a few quick items about today's event. First, all physicians in attendance will receive an AMA PRA Category 1 credit, and all other providers will receive a certificate of completion for 1 contact hour credit. Additionally, we encourage you to submit questions to Dr. Kim Thornton using the questions section of the control panel. You may send in your questions at any time during the presentation. We will collect these and address them during the questions and answer session at the end of today's presentation. Now, I would like to introduce you to today's speaker. Dr. Kim Thornton is a reproductive endocrinologist at Boston IVF. She is double board certified in obstetrics and gynecology and reproductive endocrinology and infertility. She is a clinical director of the pre-implantation genetics diagnosis at Boston IVF, the division director of reproductive endocrinology and infertility at the Beth Israel Deaconess Medical Center, and an assistant professor in the Department of Obstetrics and Gynecology and Reproductive Biology at Harvard Medical School. Dr. Thornton is a member of the ASRM Diversity Committee, the Black Boston COVID Coalition, and the Boston IVF COVID-19 Task Force, helping to ensure all patients and staff stay safe during this time. She practices out of the Waltham, Worcester, and Framingham locations at Boston IVF. We're about to get started. I'm going to pass it over to Dr. Thornton.
Thanks, Alyssa. Good afternoon, everybody. I'm glad you've been able to join us. I thought I would talk about COVID-19 vaccines in reproductive age women and really, try to address some of the issues related to mechanism of action of how these vaccines work. Just review the side effects, recommendations for vaccination in pregnancy, but this can also be extrapolated to the vaccination in women who are trying to conceive. And then hopefully we'll be able to just mention some of the myths that exist and how we might go about dispelling these myths, addressing the whole issue of vaccine hesitancy, and then answer any questions that you might have. So the COVID-19 SARS virus, or the coronavirus, belongs to a family of viruses that are called coronaviridae, which typically are viruses that attack the upper respiratory tract, leading to either mild or severe illness. And these types of viruses are not new. For instance, we have had cold viruses, which have been occurring for years, and they tend to cause very mild disease. But it was the SARS-CoV-1 and the MERS-CoV-1 that were first recognized to be viruses that were transmitted from animals to humans and potentially cause severe disease. And if you go back to the early 2000s, when SARS-CoV-1 was a pandemic, and then later, I believe in like 2012 with MERS, they caused significant morbidity and mortality, with mortality rates that were 10% with SARS-CoV-1 and 27% with MERS. The SARS-CoV-2, which is the virus that causes this current pandemic, is an enveloped virus. It has a positive strand and single strand RNA genome and belongs to the beta coronavirus subfamily. This virus has been very impactful in the US, as you are well aware. In the US, as of April 28th of this year, there have been over 32 million cases that have been reported to have occurred in the US, with over 571,000 deaths. So it's not an insignificant viral infection, and it has really changed the landscape of how we've been living over the last year, and certainly for those of us who are practicing, how we are practicing medicine and advising patients. I think by now we're probably all aware of the clinical symptoms, the most common being fever, dry cough, headaches, and shortness of breath, with non-specific symptoms being loss of taste, sore throat, poor appetite, diarrhea, nasal congestion, generalized malaise. Of the individuals that do acquire this infection, 15% develop respiratory symptoms that require supplemental oxygen, so therefore hospitalization. And 5% may actually require advanced ventilatory support because they're hypoxic, may develop ARDS and or multi-organ failure. And without going into the demographics, I think we are all aware that there have really been pretty much 2 or 3 big surges that we've experienced in the US, and in some states they're experiencing another surge, if you will, now. The most susceptible populations are certainly the elderly, those individuals with comorbidities, and the common ones that you would expect: hypertension, diabetes, heart disease, renal disease, cancer, and respiratory diseases. And then those individuals who are immunocompromised, whether it be as a result of chronic infection such as HIV, whether they're on chemotherapy or have an autoimmune disease. Our interest, of course, is pregnant women, and pregnant women also seem to be more highly susceptible to this disorder and may have a more severe outcome, and I'll cover that on the next slide. In all of these communities, there seems to be a disproportionate impact on minority communities, the Hispanic and African American communities in particular. But again, it is a disorder that is affecting all of us. So in pregnancy, the CDC is, I've found, one of the resources that is really tracking this infection and looking at the impact in different populations. So from the standpoint of pregnancy, and this is data that was published in October, so it was very early within the pandemic. They were able to survey over 1.3 million women who are of reproductive age, between the ages of 15 and 44. Of those, 461,000 had laboratory confirmed COVID, and of those women, 23,000 had confirmed pregnancy. And so 5% of those patients had confirmed pregnancy. When they looked at the outcome of the women who were pregnant, adjusting for age, race, and ethnicity, underlying medical conditions, pregnant women were more likely than their non-pregnant counterparts to have been admitted to the intensive care units. The difference was 10.5 versus 3.9 per 1,000 cases. They were more likely to have needed invasive mechanical ventilation, receive ECMO, and have undergo significant mortality as a result of this infection. I think that this was data that was, again, collected early in the pandemic, and certainly treatment for women has, for individuals with COVID has improved. But nevertheless, I think that it raises the concern, at least, that we should have for our patients who are pregnant in terms of trying to, one, keep them from getting this disorder, and then helping them recognize what the risks are if they are pregnant. From the standpoint of the fetus, I think the fetal effects still are not well understood, and there are lots of studies that are ongoing, but it doesn't seem to be that intrauterine transmission is a major risk to the fetus. Most of the neonates that are born to individuals with the SARS-CoV-2 infection were more likely to be premature, but in many instances, this was thought to be related to the fact that the moms were sick and babies were therefore delivered in order to improve maternal care. Nevertheless, there have been some studies suggesting that there may be some impact of the virus on placenta. 2 studies looked at placentas demonstrating that there were either prevalent placental injuries characterized by some thrombotic events, although there was no evidence of an acute infection. And then another study demonstrated that there was a fairly prominent inflammatory response at the maternal fetal interface. So, one of the questions is, why is this virus so infectious? And you hear a lot about the spike protein, which is depicted here on this slide, but the spike protein is the surface glycoprotein, which is what's responsible for mediating the entry of this virus into the host cells. It binds to the functional receptor, which is called the angiotensin converting enzyme 2, and then it's incorporated into the cells where it replicates. One of the key features of this angiotensin converting enzyme receptor is that it's highly expressed in the lung alveolar epithelial cells, as well as epithelial cells of many other organs, which is probably why the respiratory symptoms are so marked and pronounced. Now, this is an RNA virus, and as such, RNA viruses tend to mutate at a much higher rate than DNA viruses because of a lack of proofreading activity. So that one of the issues with this particular virus is that there are a number of mutant variants that have been identified. The original strain was the Wuhan strain, and that was the strain that was first recognized. But since then, there have been a number of mutant variants that have been identified. These variants have been categorized as to those variants of concern, or they've been stratified into variants of concern as well as variants that tend to be less concerning. And the reason that they're concerning is with this mutation, it's thought that in many instances, the infectivity of the virus increases. The other issue is also that when you talk about development of vaccines, which we'll get to in just a minute, every time there's a mutation, there's the concern as to whether or not your vaccine will be able to treat that variant. But currently, the variants of concern are listed here. This just looks at the percentage of viruses and the percentage of the variant over time. So you can see that, for instance, this B1.1.7 variant has increased in terms of its prevalence over time. So what about the vaccine development? We currently have two types of vaccines that are available for use clinically. One, the first type that was available were mRNA vaccines, so I'll talk about those first, and then we'll talk about viral vector vaccines. And I'm certainly not a virologist, so have been learning as we're going. But the mRNA vaccines are not really new in that development of this vaccine technology began back when the first coronavirus outbreaks occurred. So for SARS-1 in 2002 to 2004 and MERS in 2012. And the development progressed through phase 1 and phase 2 trials, but was never progressed past that point, was never licensed for human use. And I think for whatever reason, the disease just became less prevalent and there must not have been the need. So that having this background information regards to the mRNA vaccine made it very easy for them to then translate the information that they had into development of this SARS-CoV-2 vaccine when this new virus became mRNA vaccine is based on the principle that mRNA acts as an intermediate messenger. And what that means is it delivers a transcript or a set of instructions into the host cell. And in this case, the set of instructions instructs the host cell to create an antigen that is similar to the spike protein. So the host cell is what actually makes the antigen. The mRNA only delivers the instructions. This antigen that's developed is then recognized by the host or by your body as foreign, and the natural response is then to generate protective antibodies. mRNA, people always worry about, well, what's the risk of this mRNA getting into your system? And mRNA is rapidly degraded. So it only enters the host cell, but it never enters the nucleus. It never is incorporated in DNA. And it is just delivering a message. So there are certain advantages and disadvantages of these mRNA vaccines. First, one of the advantages is that it's relatively easy to manufacture these vaccines. And that's been, I think, helpful in, from a production standpoint in terms of making sure that we've had vaccine that's available. Second, since the mRNA vaccine is only delivering a message, and it only delivers it to the cytoplasm, it never gets within the nucleus, it's thought to be safer than some DNA vaccines. And then third, because the information delivered from the vaccine is really translated by the host translation machinery, we're more likely able to create an antigen that's going to mimic the protein structure that of the viral genome. So these are all of the advantages, of the mRNA vaccine. Disadvantages is that it's hard to store and transport. And so part of the challenge with delivery of both the Pfizer and the Moderna vaccines were the requirements for them to be stored and transported at ultra low temperatures. And this is a characteristic of all mRNA vaccines. Viral vector vaccines, on the other hand, which is the Johnson & Johnson vaccine, is a viral vector vaccine, uses a modified virus, which is the vector, to deliver, again, the genetic code for the antigen, which in this case is, again, the spike protein. And then the cell in which the viral vector resides produces the antigen. So again, it's just providing instructions. There are a number of viruses that have been modified to be used as vectors, and we're familiar with many of these. So for instance, the adenovirus, measles virus, vaccinia viruses have all been used as viral vectors, and they're stripped of the disease-causing genes, but so that they can still be used to transport the instructions, though, that we need in order for our host to make that antigen. And the other characteristic of both of these vaccines is that the antigen, once it's made, it triggers not only a cellular response, but a humoral response. So, that's another advantage of these vaccines. Disadvantages of viral vector vaccines is that if you've been exposed to the vector before, it may not be quite as effective, and they're a little bit more complex to manufacture. And so it impacts how quickly they can be scaled up to be manufactured for large volumes. So for all of these vaccines, in January, the mRNA vaccines were approved. Actually, Pfizer was approved in December of 2020, Moderna a week later, and then in March of 2021, we got emergency authorization use for the Johnson & Johnson vaccine. Differences between the currently available vaccines is that the Pfizer is a 2-shot. Both Pfizer and Moderna require 2 shots. Pfizer 3 weeks apart, Moderna 4 weeks apart, and the Johnson & Johnson is a 1 shot. One of the things with all of these trials is it was the concern that, even though they tried, when they were doing the phase 3 trials, they tried to be as inclusive as possible. They didn't really include pregnant women in the trials, and I don't think it was very clear whether they were including infertile women. That they also didn't include lactating women. But in February of 2021, actually I think it was in January, and then February it was reaffirmed. The Society of Maternal Fetal Medicine and ACOG came out with a statement encouraging that the vaccine be available for pregnant individuals. And then later the ASRM and the World Health Organization also supported this claim. And fertility was not specifically studied, that there was enough evidence in the general population regarding the safety of these vaccines, that, and with the mechanism of how these vaccines worked, that they should more than likely be safe in pregnant women. And then they encouraged inclusion of pregnant women in clinical trials moving forward. So, and again, the recommendation was the mechanism of action for the mRNA vaccines was reassuring. In the animal testing, so in your earlier phase 1 trials, vaccines did not affect fertility, nor did they cause problems with pregnancy in animal models. These are not live vaccines, so they don't contain virus particles, so there is no risk for contracting COVID-19. And then the mRNA particles are eliminated very quickly, so it's even unlikely that mRNA particles would be able to even reach or cross the placenta. And then finally, and I'll share with you 2 of the studies that have recently been published about the immunity that pregnant women may develop, may actually help to keep the baby safe after birth. So although pregnant women have not been included in a lot of trials, the vaccines, once we started the rollout of the vaccines, there was a registry where patients could register so that you could, do longitudinal follow-up. And the VSafe program, which is an online program, enrolled, and this is data that is, I think, it may be through January, I forgot the exact timing, but at any rate, enrolled 35,000 participants who identified as being pregnant. And then of those, 3,900 participated in the registry and presented, the outcome of their pregnancy. And from that, it didn't seem like there was any increased risk in pregnancy loss, with pregnancy loss rates, and these are both first trimester and second trimester, of about 13.9%, and live birth rates of 86% in those patients who participated, with no significant adverse neonatal outcomes. And this study is, this registry is ongoing as individuals get vaccinated. So when we talk about how effective, the efficacy of vaccinations and effectiveness of vaccinations, efficacy is the percent reduction in a disease under an optimal clinical trial situation, whereas effectiveness reflects how well the vaccine works if you just give it in the community. So the efficacy of these vaccines thus far, the Pfizer and Moderna, their efficacy against development of severe disease is in the 94 to 95%. The Johnson & Johnson, the efficacy is 72%, and AstraZeneca is in the 80% range. One of the comments that's been made about some of the earlier studies is as you get more and more variants, the efficacy of the vaccines may decrease. But the key is that all of these vaccines reduce the risk of very, very severe disease. And this is in patients who are pregnant or non-pregnant. So in patients who are pregnant, though, one of the things that we want to know is, well, if you get the vaccine in pregnancy, is there any impact on antibody production in breast milk, antibody production in cord blood? And recently there were two studies, one out of that was published out of the Brigham and Mass General, looking at 131 reproductive aged vaccine recipients. And this group included 84 pregnant women, 31 lactating women, and 16 non-pregnant women. And they looked at vaccine-induced antibody titers and documented that they were equivalent in women who were pregnant, lactating as compared to non-pregnant women. And they were able to compare the antibody titers in these women to women who had had SARS and SARS-CoV-2 during pregnancy. And the titers of the antibody titers were significantly higher in women who had been vaccinated than in women who had just had an infection, which is important. And it's important information to relay to your patients who say, well, I've had the infection, I don't need to get the vaccine. That's probably not true. And then the second booster dose further increased the SARS-specific IgG in maternal blood and in breast milk. It didn't do that with the IgA, but certainly with the IgG antibodies. Another study, and this was done at Cornell, which was just published last week in the Green Journal, looked at 55 pregnant women who were vaccinated by the time of delivery. And hold on a second, I'm sorry. Actually, it's 122 pregnant women. 55 had received one dose of the mRNA vaccine, and 67 had received both vaccine doses by the time of delivery. And one of the things that was notable in this study is that in those who received only one vaccine dose, 44% had cord blood samples that had detectable IgG, whereas 99% had detectable levels if they had received both vaccine doses. And this is just a different slide from that paper demonstrating the ratio of mothers with either no antibody response, no passive immunity, or passive immunity that was relative to how far off they were from their vaccine. And I don't think I need to go over this a lot. I think it just reiterates what I've already said. Now, side effects of the vaccine are not uncommon. Common side effects are usually pain and swellness or swelling at the injection site. Some individuals might have fever for 12 to 48 hours after an injection, headache, fatigue, muscle pain, kind of the typical things you expect after a vaccination. It's very rare, however, that individuals have an anaphylactic reaction. And I think that kind of anecdotally, most people, if they've never had a COVID infection and get vaccinated, the first vaccine is pretty well tolerated, and the second vaccine is where these symptoms tend to be a little bit more prevalent. And I think that that's just a reflection of the fact that the first vaccine is really introducing the antigen to your system, and then the second is a boost. And at that point, your body is really revved up and able to respond, and you obviously feel the systemic effects. Now, with the Johnson & Johnson vaccine, one of the rare, in addition to the side effects that I mentioned, one of the rare side effects is this thrombosis with thrombocytopenia syndrome. And it's a rare blood clot that occurred, at least it was initially reported in 6 women, some occurring sometime between 6 to 13 days after vaccination. And what was notable is all of these individuals had a thrombosis in their cerebral venous sinus, and it was accompanied by thrombocytopenia. So at that point, there was a pause by the FDA. They stopped administering the J&J vaccine and reviewed their data. And then, and they reviewed their data in light of the, considering the overall risk of this occurring in the general population again, the benefits of being protected against COVID, and finally authorized use again, with a precaution that women younger than 50 years old should be aware that there is that risk of blood clots with low platelets after vaccination, and that with other vaccines, this has not been seen. But nevertheless, looking at the risk and benefits, felt like there was still a reason to allow vaccination to continue. So I'm going to talk a little bit about vaccine hesitancy. With all of this information, there are lots of people that we'll talk to, and you'll have some individuals who are going to be right on, on board with going ahead and getting the vaccine, but there are still a lot of people that are opting for this wait and see how the vaccine is working before they decide to get vaccinated. And certainly this phenomenon occurs in certain populations. Black and Hispanic adults are more likely than white adults to have a little bit of hesitancy. There's certain patients in political parties, or whether they're living in rural settings, that might have some hesitancy. So we have to just accept that this is the case. Even within the medical field, there are 30, or none, I shouldn't say just medical field, but the medical field and other essential workers in fields who are, potentially at risk, highly at risk. There's hesitancy then, and they will, people have said that they're only going to get vaccinated if it's required by their work or school or what have you. And then the perceived side effects of the vaccine are perceived and real side effects, I guess I would say, are a concern to many individuals within the public. There are lots of misconceptions. The misconception that if you get a vaccine, you're going to get COVID. Well, that's not true. We know that it doesn't carry a live virus, so that therefore there's no way that you're going to get the infection from the vaccine. The vaccine will cause infertility or increase miscarriage rates. This was initially circulated because there was some concern that the antigen response, or I'm sorry, the creation of the spike protein would induce an antibody response that would interact with a protein in the placenta called syncytin-1, and this is not true. This is, this does not, vaccination will not impair fertility or pregnancy outcome. Some people think that if they've had COVID, then they don't need the vaccine, and I think that one of the pregnancy studies that I mentioned, as well as other studies, have suggested that natural immunity from COVID may not last very long, and it also may not be quite as robust as the immunity that you get from the vaccine. And we still don't know how long the immunity from the vaccine will last, but we think at least for 4 to 6 months, and there may be longer. Lots of people are concerned about the development being too fast. And again, just to reiterate that the mRNA vaccines have been developed with under development for years. And with mRNA, with the technology nowadays, it's much easier to make these vaccines. Many of the steps to roll out the vaccines and conduct the clinical trials, instead of occurring in what is typically a sequential path, occurred in parallel. So, and this was really because industry and there was some government money invested in the research and or paid for the vaccine in advance, so that the companies had the money to do this. And then there was a lot of vaccine that was made and waiting and ready to go before the FDA actually authorized the use. And I think that there was just generalized recognition that we needed to do something and have this vaccine available when authorization came about. Other misconceptions that if you're fully vaccinated, I can stop wearing the mask and stop taking precautions. Not true again. The vaccine and developing antibodies doesn't necessarily prevent you from getting an infection. It really stops the development of severe disease. And, I can speak to the fact that, we know people who have gotten a mild disease or have been carriers of COVID who have been fully vaccinated. We've talked about side effects. By and large, the side effects are, common, not particularly severe, but there's no question that there are some serious side effects, but the risk overall and the rate at which these severe side effects occurs is still small. And then, finally, another misconception is DNA vaccines will change your DNA, and that's not true. The mRNA vector virus vaccines and the viral vector vaccines, none of them enter the nucleus, and they're all quickly degraded. So in terms of counseling patients regarding vaccination, I think that the key is to really present the data in a way that patients can understand, how the vaccines are developed, what the efficacy is of the vaccines, and the reason for vaccination, but also acknowledge whatever their concerns might be. Recognize that there has been and may continue to be politicization of the pandemic. Acknowledge that the rollout of this whole rollout of vaccinations, etc., has not been flawless, but that we're trying to do the best by all of our constituents. And then if they're not necessarily on board, still recognize that you can revisit this at a later date. And so I would always encourage patients to consider at different encounters discuss this again if they've chosen not to get vaccinated, because they may change their mind. So with this, I think let's open it up to questions so that we can have a discussion about questions that you guys might have.
Thank you, Dr. Thornton. Great presentation. We're going to start opening up to questions submitted during today's presentation. As a reminder, you can still submit questions through the questions pane in your attendee control panel. Our first question is, do you have any information on preterm birth rates for women who have had COVID versus patients who have not, and also for patients that have had the vaccine? Is there any information that you can share on that?
So with regards to preterm birth rates, I don't have the exact figures. I think that the risk of women who were infected with COVID and were delivered preterm or there was a higher risk, and I'm sorry, I don't have those exact numbers, but related to the vaccine, I don't think that there's any data with regards to preterm birth rates.
Okay, next question. I've had a number of young female patients who have reported amenorrhea after their second vaccine. Have you heard of this? Is it transient?
That's something I have not heard of. So I'd have to look into that. I have not heard that, and I'm assuming these are in women who have otherwise regular cycles. So
Yeah,
I was not aware of that.
I think that's a newer thing that people are talking about right now, so it's probably something we could look into. Is there a specific gestational age at which you would recommend the vaccine? Let me just see if I can pop this out to make it a little bit bigger. I think that's what it was. Sorry, is there a specific gestational age at which you would recommend the vaccine, or just the sooner the better?
I think in most individuals, we're not limiting vaccination to any particular gestational age. I can speak from personal experience for patients who are undergoing fertility treatment. The only, I think the guidance that we're giving them is that we don't want them to get the vaccination within 3 to 4 days of starting treatment, just because in the event they develop a fever, it's very hard to distinguish between a fever from vaccine, potentially fever from an acute infection. But in general, I don't think there's any restriction to when in pregnancy vaccines can be administered. We've not limited it to any particular gestational age. I think you have to, though, have a conversation with your patients. Some patients may choose to wait. If they're already pregnant, they may choose to wait until the second trimester. I think that you have to just make a decision as to when you're going to give the vaccine based on what your recommendations are, and then what the patient's comfortable with.
Thank you. Our next question is, when would you recommend pregnant women to get the vaccine?
I think that's pretty much the same. I think that they can get it at any time during pregnancy that they feel comfortable.
Okay, they wanted to know if there's any specific trimester that you think that would be more comfortable for them.
I don't think that there's any specific trimester that you couldn't give the vaccine in. I think I've had patients who particularly have asked, should I just wait until the second trimester? And if that's what they're most comfortable with, then that's what I recommend. I think that, or that's what I will be supportive of, but there's no reason not to give it in the first trimester.
Okay, and then this is kind of going on that again, but what about getting the vaccine in early pregnancy and developing a high fever, risk for anomalies?
So in terms of risk for anomaly, I think that in general, the fever is not long-standing. For patients who are getting the vaccine, we usually recommend that they, would take Tylenol if their fever gets extraordinarily high. I don't think that there should be a significantly increased risk, but I'm not sure if that's been looked at that closely yet.
Okay. The next question is, how would you respond to patients who ask, why would I receive the vaccine if I am pregnant and it has not been thoroughly studied on pregnant women? This is a very commonly asked question.
So, I think, again, it's a risk-benefit assessment. And given what we know about the mechanism of action for the vaccines, and, the fact that we think that they're safe based on the fact that mRNAs are rapidly degraded, or even the viral vector is rapidly degraded, and this does not cross the placenta and it does not cause disease. And knowing that if an individual contracts the COVID-19, she may have a much more severe course. Certainly patients have to weigh those risks versus, the benefits of getting the vaccine and reducing the risk of severe disease. And so it's a matter of just kind of shared decision-making between you and the patient as to whether or not they, are comfortable going forward. Certainly, there's some patients I've had that have said, I'm just going to stay home and continue to wash my hands and wear my, mask and just avoid contact with the public. And, you can be supportive of that, but there doesn't seem to be any reason not to get the vaccine in pregnancy.
Okay, the next question is, what do you think about starting low-dose aspirin in women who have COVID infection in early pregnancy? Probably because of blood clots, I guess they're worried about.
Yeah, I'm not so sure that I am an expert and can speak to that. So I'm going to defer that question to the obstetricians. I haven't seen that as a recommendation, a routine recommendation.
Okay. Do you recommend dancing around the Tdap, not within 2 weeks of Tdap on either side?
I think in general, the recommendations for the COVID vaccine is that you shouldn't have another vaccine within, you should space your vaccinations out. So you shouldn't have another vaccine within 2 weeks. So I'm not sure what the dance your way around Tdap is, but I would space them.
Sounds good, thank you. And the last question right now, unless there's more that come in, is I feel that infertility myth is very common, and I've heard it from both women and men. What do you think is the best method to display these myths?
So the best method, I think, is just to show them the data. There is no data that suggests that either COVID-19 or the vaccine would cause infertility. So I think, one of the things with fertility is there is a lot of myths about what can cause infertility, and you have to just have an honest conversation with them that that's, a fallacy, and go from there.
Okay, and we actually do have one more. Should we counsel patients to not get the J&J vaccine if they are on OCPs? So I guess regarding clotting.
So I haven't seen any data to suggest that that would be the case. Because I don't think we know necessarily, what the risk factors are. I think if a patient has a particular concern about a vaccine and there are alternatives, then maybe they should choose a different vaccine. In most instances, the recommendation has been to get the vaccine that is available to you, because the risk of severe disease is so much more severe than the risk of any of these side effects occurring. But I've not heard of any recommendations for baby aspirin or other anticoagulants if you're going to get the Johnson & Johnson vaccine.
Great, thank you so much. I think that is the last question. Thank you so much, everyone, for joining and attending today's webinar, COVID-19 Vaccine and Fertility, Treatment Guidelines and Advice for Providers. If you have any other questions, you can reach out to myself, Alyssa Cooper, at ecooper@bostonivf.com, or on my cell, 978-302-2958. Once you leave today's webinar, you will receive a survey on the presentation, and we would appreciate it if you could provide your feedback. You will also receive a follow-up email within 24 to 48 hours with a link to view the recording of today's webinar. So feel free to pass it on to anyone that missed it. On behalf of Boston IVF and Dr. Thornton, thank you so much for joining us today, and enjoy the rest of your day. Thank you, Dr. Thornton.
Thanks. Bye.